Hey, good evening, everyone. Just a minute. Hi, good morning, everyone. Yeah. Good evening, everyone. So let us just start with the series. Okay. So I welcome you all to Unacademy. So let us just start. Actually, I clicked the wrong link and I was seeing myself one day before that very same. I thought I've taken this class, so how can I be again? Okay. So anyways, so let us just start with the series, and we have a lot of offers going on, so you can avail them before the price hikes. And we have a lot of features loaded in an academy and lot of new batches coming. So please do join an academy. So let us quickly start with the today's session. So let us talk about the golden pearls of surgery. So when we talk about the golden pearls of the surgery, what are the important things that we are going to discuss today? Let us see all of them. Okay. Now we are going to discuss some important things related to trauma. Some important things related to trauma. Some special type of traumas here. Ram Ram Krish. Yeah. Some important types of injuries and some important protocols. So when we talk about when we talk about trauma, the most important thing that we have to understand is the concept of triage. Now when we talk about the concept of triage, what does triage means? Triage is a term which means to sort. There are two three important things that we can get on the concept of triage. Like, what is the indication of triage? What is the indication of triage? Triage is indicated when demand overrules. So when the demand overrules supply, and this is what is when we have lot of patients but the medical facilities are limited. So there you have to bring the concept of triage when demand overrules supply. Now we all have to understand what is the aim of triage. The aim of triage is very 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 simple. The triage doesn't mean treat everyone who wants the treatment. Triage is a very simple straightforward concept to maximize treatment from limited resources. So we need to maximize treatment from limited resources. Now again, who is doing the triage? Yeah, who is doing the triage? Answer is the triage is done by the paramedical staff. And when it is done by the paramedical staff, they are not trained enough to identify what is what injury. So we have a color coding system for them. And what is that color coding system? So this is very 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 important, the color coding system. When we talk about this color coding system, when we talk about this color coding system, we have red. Red is given the maximum priority. So priority wise red, then we have yellow, then we have green, and then we have black. So this is how we prioritize the things: red, yellow, green, and black. Remember, in priority status, red is given the highest priority. The red is given highest priority. And when we talk about highest, what do we mean? They include the patients who require urgent life saving intervention. So these patients require urgent life saving intervention. And this is very 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 important. So they cannot be denied, nor can they be delayed. Yeah. yellow Yellow category is a patient who are actually a candidate who require intervention. Like, suppose you have a fracture with a bleeding, and a standard fracture, like fractured shaft of femur with bleeding and a fractured radius. Both of them will require a treatment. But if you delay the fracture shaft for immobilization for some time, it is not going to worsen the scenario. So, bache, yellow are the patient who cannot be denied but can be delayed. So, they require intervention. They require intervention but not life saving. So, they require intervention but not life saving. So, this is again very, very, very important. Then we have something in the green. What do you mean by green? Who are these green? Students, these are ambulatory patients. What do you mean by ambulatory patients? They can walk, they can talk, and they don't have any morbidity, or you can say they have no restriction. So, who are they? They are the one who require only the first aid. First aid, you can say management. So, they are happy with the first aid, and that is why they are the most useful. Why they are most useful? Because whenever we talk about any rescue or disaster management, the biggest problem is the shortage of manpower, and they are the one who can help you bridge that gap. But say, imagine if you take these patients to hospital, they will add nothing, but they will add to what? Chaos. So they will either narrate their stories, or they will be flirting with the sister, or they'll be just hampering the work of this resuscitation. Black. When we talk about black, who are the black? Yeah, black. By black we mean they are either dead or moribund. So they are given least priority. Why they are given least priority? Because either they have died or they are about to die. Okay. So dead or moribund. Now when we talk about the concept of triage, we also have to understand the way of communication between the disaster and the hospital site. So for that we have a concept of mist. What do we mean by mist? What do we mean by mist? It is the protocol. It is the protocol for sharing patient information. So it's a protocol for sharing patient information from disaster site to hospital site. And this is very, very, very important. So from disaster site to hospital site. Now let us try to understand one more important concept about this mist. What is? What are the parameters which are included under mist? M stands for you have to mention the mechanism of injury. So mechanism of injury has to be mentioned, point number one. Then I is injury or injuries identified. So injury or injuries identified, this is I. Then S stands for signs. That means vital signs. Yeah, vital signs at the site. So at the site of the accident, what are the vital signs? These are very important. Then T is the very important thing, that is treatment given. So treatment given is also very, 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 very important, and this is what is included under this mist. So mechanism of injury, injuries identified, signs, and treatment given. You have to mention why. Until unless you don't tell the patient, you don't communicate what treatment has been given, you will replicate the same management. So this is about the triage. Next, very important concept that we are going to discuss is the concept of patient survey. So when we talk about patient survey, what are the important points? The patient survey is defined as the assessment of the patient, the clinical assessment of the patient. Now, when we talk about the clinical assessment, the very important thing that we have to understand that there are two types of clinical assessment. The first clinical assessment done. What is that? The first clinical assessment done? Answer is, this is known as primary survey. So the first clinical assessment done, this is equal to primary survey. So what is the intention behind primary survey? The intention behind primary survey is to look and rule out any immediate cause of death. Let's say the prospect of patient survey is to save the life of the patient, and if you cannot, then you are a loser. Remember, the clinical assessment done post hemodynamic stabilization. So post hemodynamic stabilization, the clinical assessment that we do, this is what is known as secondary survey. Are you getting this? So we have primary survey and we have secondary survey. Both are very, very, very simple thing. But say, always remember, we always have a doubt that when will we start with the resuscitation? This is very important for you all to understand that patient survey and resuscitation. So patient survey and resuscitation, they all are done what? Simultaneous. So they both are done simultaneous, and this is very, 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 very important. So they are done simultaneous. Now when we talk about resuscitation, this is also very important. When we talk about resuscitation, there are 2-3 things that you all should know. Bachi, what is the fluid of choice? What is the fluid of choice? Then what is the rate of infusion and what is the volume of infusion? So volume required and the rate of infusion, and for all these purpose, what is the cannula that you require? Yeah, what is the cannula? Fluid. Let us discuss all these things in this small discussion only. So first I will complete the patient survey and then we'll go to this resuscitation part. Yes, we will go for crystalloid decay. Ringer lactate can be given, but we prefer normal saline. One normal saline or 0.9% normal saline is the ideal thing. So let us talk about this. This is very, very, very simple. Now primary survey. So I'll come back to this resuscitation, but let us understand this primary survey. Now when we are talking about primary survey, what are the important things that we all have to understand? So after stabilization, or you can say after securing airway. So after securing airway and along with that plus stabilization of C-spine, of cervical spine, you will start the assessment. So these are the 2 things that we need to do, and then you will start assessment of airway breathing. Yeah. So start assessment of A for airway. We have breathing, we have circulation. So A for airway, breathing, circulation, disability, and also exposure. Are you getting this? So airway, breathing, circulation, disability, and exposure. This is very, 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 very important. Now when we talk about, I'll discuss Krish the cannula numbers also. I'll discuss that part. So when we talk about stabilization of C-spine, you know this is done with a what? This is done with the help of what? Philadelphia collar. So this is done with a Philadelphia collar, with a special collar which is a hard collar, Philadelphia collar. How do we secure the airway? Now airway securing. So if you see the individual like this, yeah, if you see the individual like this, you have to align the airway. To align the airway should come front. Yeah. So what is this? This is chin lift. This is chin lift. What else? What is this? What is this? This is neck tilt. So chin lift. This is neck tilt. Chin lift, neck tilt. What else? We have jaw thrust. So chin lift, neck tilt, and jaw thrust. There are 3 very, 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 very important things. Yeah. Next is when we talk about securing airway, Philadelphia collar. Why do we do this? Because the most common cause of the death could be a compromised airway. That is the reason. Now we are doing assessment of airway, breathing, circulation, disability, and exposure. Why exposure is important, students? Exposure is very important because unless you expose the patient, you don't come to know about the concomitant sites of injuries. Suppose patient has been brought to you with abdominal trauma. There may be a thoracic injury also. Yeah, there may be thoracic injury also. So there may be extremity injury also. You need to expose the patient. The second problem is, suppose this is a patient of burn. The patient has attempted emoliation by sprinkling over what may be kerosene or any gasoline product. And now, unless you don't remove this contaminated clothing, you cannot get a clear environment. So E for exposure and environment. How do you assess the disability? With the help of what? GCS. Now, one very important thing is many students are confused. Sir, we know everything, but people are saying that nowadays we give priority to the circulation C, A, B, C, D, E. Just laugh at them because they don't know anything. Why? I'll tell you. But just C, A, B, C, D means, look, what is the intention? You have to understand the intention of primary survey. The intention of primary survey is to save the life of the patient. So, bache, if there is any active, ongoing, visible, catastrophic bleeding, you have to secure that. And how? Just put a tamponade with a cotton and then roll a bandage. So, control, C stands for control any life threatening. So, control any life threatening bleeding first. So, control any life threatening bleeding, point number one. And after that, start with A, B, C, D, and A. If present, if present. Is that clear to everyone or no? The next is, let us talk about the concept of secondary survey. So when we talk about the concept of secondary survey, the intention of doing a secondary survey is to find out conditions which can modify the outcome of the patient. To find out conditions which can modify the outcome of the patient. And therefore we have a mnemonic for them which is known as ample. This is ample. A stands for, let us find about the allergies the patient has. M stands for medication. The medication on which the patient is. There could be a possibility that patient is on antihypertensives, on blood thinners. So you need to know about them. P stands for past medical history. L stands for last meal. Why last meal? Because you might require to intervene with what? A surgery. So when we are talking about surgery, we require a NPO status. So NPO status of 2 to 4 hours. 2 to 4 hours for clear liquids, and 6 to 8 hours for solids. And then E is events of trauma. So this is how we do the primary and the secondary survey. Now let us see how we plan resuscitation of this patient. Now, this is again very, very, very interesting and simple thing. Resuscitation. Now, when we talk about resuscitation, the first question is, what is to be done? Insert a cannula. What is a cannula of choice? On one side, I will write size. On one side, I will write flow rate. And one side, I will write the use. Yeah. So, in case of resuscitation, we will use orange, which is 14. So, size and color, okay, so orange is 14 French. Orange, this is having a flow rate of what? 240 ml per minute. Basically it is 240 to 300. Then we have gray is 16 French and it is 180 ml per minute. Yeah. Then we have white. It is 17 French, 120 ml per minute. Then we have green. This is 18 French, 90 ml per minute. Then we have pink, which is 20 French. This is 60 ml per minute. Then we have blue. Okay, I'll revise, Krish, again. I'll revise. 22 French and it is having 45 ml per minute. Then we have yellow, which is 24 French and it is having 30 ml per minute. And then we have violet, which is 26 French. This is 15 ml per minute. Okay, I'll tell something about them and then I'll tell you, I'll revise primary and secondary survey with you. But orange, grey and white, they are all used for rapid resuscitation. Rapid resuscitation. Remember, during surgery, we can use green. All infusions, all IV infusion, you are going to use what, students? Pink. All IV infusion. Blue, violet, and yellow. They're all pediatric. They're all pediatric. They're all pediatric. Are you getting this? Krish, by primary survey, you look at the urgent immediate causes of death. And secondary survey, in primary survey, you will assess airway, breathing, circulation, disability, and plan exposure. In secondary survey, you will find out certain important information which might modify the outcome, like allergies, medication, past medical history. In case you are dealing with a female patient, you should always be knowing the pregnancy status of that lady also, last meal and event. So these are the factors which modify the outcome of the condition. So resuscitation, first we have seen the cannula. Every year you have one question on cannula. The next thing is what is the choice of fluid? What is the choice of fluid? Now this is again very, very, very important. Always remember the first line. The first line is crystalloid. The first line fluid replacement is crystalloid. And remember, if there is massive requirement of fluid, then you will not give crystalloid. You will not give crystalloid. You will add rather blood now. So don't keep on adding crystalloid one after another. I'll give you damage control resuscitation protocol. There you will understand that. Important is, one very important point that all of you should be knowing is, important is, colloids are contraindicated. So important is that colloids are contraindicated in first. So colloids are contraindicated in first 12 to 24 hours. In first 12 to 24 hours. This is what is very, 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 very important. So colloids are contraindicated in first 12 to 24 hours. Next, very important thing. So this is a basic idea. This is a basic idea about the fluid. Let us move forward. What volume and at what rate? This is again very important. So let us see the volume requirement calculation. So volume requirement calculation. So when you talk about volume requirement calculation, we have two formulas: volume in ml per day and volume in ml per hour. So volume in ml per day and ml per hour. Yeah, very good, Krish, very good. So ml per day versus ml per hour, we have first 10 kgs, then we have next for the second 10 kgs, and then we have the further kgs. Then we have further kgs. So first 10 kgs, second 10 kgs, and further kgs. When you talk about ml per day, what are the important things that we all have to understand? We all have to understand. It is 100 ml per kg for first 10 kgs, 50 ml per kg for second 10 kgs, and 20 ml per kg for further kgs. So 150, 20 ml per hour, 4 ml per kg for first 10 kgs, 2 ml per kg for next 10 kgs, and then 1 ml per kg for further kgs. So it's 150, 20, 4, 2, 1. Let us see this in the question also. Yeah. Example, let us calculate it for 80 kg per individual. For a 80 kg individual, we have 100 for first 10, 50 for next 10, 20 for remaining kgs. So this is 1500 and this is 1200. So the total is 2700 ml per day. 2700 ml per day. This is very, 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 very important. Next is, when we talk about in ml per hour, we have 4 ml per kg for first 10 kgs, 2 ml per kg for second 10 kgs, and then along with that 1 ml per kg for remaining kgs. So this is what? This is 60, and along with that one more 60, so 120 ml per hour. So the next challenge is, you've got the fluid requirement. Yeah. How to convert this into what? Ml per hour. Very good question. Ml per hour. Now, so let us see rate calculation. So volume we have seen. Now we have rate calculation. When we talk about rate calculation, it is represented as drops per minute. Drops per minute. Drops per minute. This is equal to dpm. So there are two tricks to remember this drops per minute concept. Let us see. Drops per minute is defined as volume in ml per day divided by 100, or volume in ml per hour divided by 4. Let us try to understand this. Volume in ml per day divided by 100. Like if it is 2700 ml per day, that is going to be 27 drops per minute. 27 drops per minute. Yeah. Let us try to understand. If it is 4200 ml per day, how many drops per minute it would be? 42 drops per minute. Very easy. Very easy. Very good question. Now, if you talk about the volume, suppose 200 ml per hour, that would be 200 divided by 4 is equal to 50 drops per minute. So this is how volume in ml per hour divided by 4, or volume in ml per day divided by 100. This is how we start with the things. Next is, so we have got the cannula, we have got the fluid, we have also got the way. But one very important thing about resuscitation in emergency, let us see. So now we are going to talk about the concept of damage control resuscitation. So what is the important concept of damage control resuscitation? Now this is very important. So these are the golden words that you have to remember. Always think that the first is limited use of crystalloid. So limited use of crystalloid. Don't think that you can replace everything by crystalloid. 6 liters of blood, 2 liters lost, 4 liters is there. You added 4 liters of fluid. Ultimately what will happen? The blood will be diluted. And blood will be diluted to an extent that patient will have what? Coagulopathy. All the coagulation factors will be what? Dilated. So limited use of crystalloid. So limited use of crystalloid. कितना कर सकते हैं? Yes, 1 to 2 liters. 1 to 2 liters of normal saline or RL. इससे ज़्यादा नहीं. So 1 to 2 liters. And remember, important is, out of this 500 ml, 2000 ml maximum can be given as what? As bolus. As bolus, rest is maintenance. And the rest is maintenance. Is that clear to everyone or no? Limited use of crystalloid. Now you have a patient who has lost blood, so replace blood by blood. So blood transfusion, blood and blood product transfusion. So blood and blood product transfusion. So second point, blood and blood product transfusion. The third important point, so limited use of crystalloid, blood and blood product transfusion. The third is permissive hypotension. What is this permissive hypotension? There was an intern who was giving fluid after fluid. I said, why are you giving? Sir, patient is not maintaining blood pressure. I told, it's not my job. The higher the pressure, the more is the blood loss. So right now, if you want to save the life, don't run behind blood pressure. Allow it to fall up to a permissible limit. So permissive hypotension. And when we talk about permissive hypotension, what do you understand with this term permissive hypotension? Answer is, you can allow this to fall. Remember, up to the target map is 65 to 70 mmHg. And this is very, 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 very important. So permissive hypotension. The fourth is trial of hypertonic saline. So trial of concentrated version of salines. Yeah. So hypertonic saline. So with the 2 liters of normal saline versus 200 ml of hypertonic saline, you will have a larger volume expansion and better control of blood pressure. So trial of hypertonic saline. One more important thing is use of cryoprecipitates. So to improve the plasma coagulative function. So cryoprecipitates, point number 1. You can use tranexamic acid, early use of tranexamic acid. So early use of tranexamic acid, cryoprecipitates are very useful. So tranexamic acid, cryoprecipitates and recombinant factor 7. So they are all very, 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 very important. Very important. Let us move forward. Now, when we are doing the resuscitation part in the trauma bay, the next is we also need to evaluate the patient on some important parameters. So, bachche, is the patient under any point of shock? The shock is again a very important thing. So when we talk about shock, in emergency, we get to see all 4 types of shock. So it can be hypovolemic shock, it can be hypovolemic shock, it can be cardiogenic shock, it can be neurogenic shock. So cardiogenic shock, neurogenic shock, and it can be septic shock. So there are 4 types of shock. So when we are having an overview, let us compare the heart rate. It is elevated in all except the septic shock. Why septic shock is why neurogenic shock? Why? Because neurogenic shock is a condition where there is generalized sympathetic loss of there is central loss of sympathetic tone. So neurogenic shock, it is going to decrease. Yeah, it is going to decrease. Respiratory rate, it is going to increase in all except again the neurogenic shock where you get to see bradypnea. So you will get to see bradypnea. Next is, let us talk about CVP. CVP is low for all except the cardiogenic shock. Why? Because of the blockage that is created. So cardiogenic shock, we have high CVP. This is very, very, very important point. What else is important? Next is, when we talk about extremities. So when you talk about extremities or the peripheries, the rule of shock is to conserve the fluid, conserve the oxygen, give it to vital organs. So there is increased peripheral resistance in this case. There is increased peripheral resistance and hence vasoconstriction. So the extremities are cool in both hypovolemic and neurogenic shock. And why? Because of the concept of vasoconstriction. In case of neurogenic shock, the extremities are dilated and they are warm. So in this case, there is vasodilatation. Yeah. So cool versus warm. Last is when we talk about septic shock. In the initial phase, it is under the effect of toxin. It is warm. Later on, as the shock overtakes the body, it becomes what, students? Cool. So warm versus cool. The next is very important thing, component of sepsis. Component of sepsis is negative for all. So how do you see sepsis? Or you can say leukocytosis. Yeah. Then we have a very important thing, that is MVOS. What do you mean by this MVOS? MVOS stands for mixed venous O2 saturation. So at the level of pulmonary artery, or you can say at the level of right atrium. Basically, we put the Swan-Ganz catheter in the pulmonary artery So we see the saturation. So this is defined as oxygen saturation at the level of pulmonary artery, or you can say right atrium, right atrium. Normally, normally it is somewhere between 65 to 70%. So basically, it is telling you the oxygen saturation of the blood which is returning back. If the shock is like hypovolemic or cardiogenic, when lesser amount of blood is going, more oxygen will be extracted, and you can expect a low MVOS. A low MVOS means the blood is extracted with a larger proportion of oxygen while the tissue or the body is still under the effect of shock. And low MVOS says that the shock is still undergoing. Similarly, neurogenic shock, the blood is pooled in the peripheries and very less blood goes for the extraction. So they have lesser oxygen extraction and higher. In sepsis, under the control of infection, the body loses the metabolic exchange, and again here you are going to have what? High MVOS, high. So what do you mean by low? Low means less than 50%. And what do you mean by high? High means more than 70%. So these are very important things. The next thing that we all have to understand is what is the concept of their management. So when we talk about hypovolemic shock, you require fluids, and that is crystalloids plus minus blood. Now, if you talk about cardiogenic, you have to go for fluid restriction, and not only this, you need to add inotropes. So inotropes, dobutamine, noradrenaline, ADR, these are the drugs. Now when you talk about neurogenic shock, you need to add fluids also. So fluids, and along with the fluids, inotropes. So fluids plus inotropes. Then if we talk about the septic shock, what do you know? What do you need for septic shock? You need fluids, yes. Along with the fluids, what else you need? Antibiotics. You need antibiotics. So we need fluids, we need antibiotics, and along with this, you also require inotropes. So fluids plus antibiotics plus inotropes, they are all very, 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 very important. Next is we might often get a question on hypovolemic shock and its grading. So let us talk about the grading of hypovolemic shock. Now when we talk about hypovolemic shock, what are the important points that we all have to understand? What are the grades? We have 4 important grades: grade 1, grade 2, grade 3 and grade 4. So the first is on the basis of percentage blood loss. When you talk about percentage blood loss, grade 1 less than 15, grade 2 15 to 30, more than 30 up to 40 and more than 40. So this is just like a tennis match score, and that is why this classification is also known as what? Tennis classification. So this is also known as tennis classification. Is that clear or no? Along with that, you can have in ml blood loss less than 750, 750 to 1500, 1500 to 2000 ml and more than 2000 ml. Yeah, blood loss. Then heart rate per minute. This is less than 100. Grade 2 more than 100, grade 3 more than 120, and this is more than 140. So less than 100, more than 100, more than 120 and more than 140. Then students, systolic blood pressure is normal for grade 1, normal for grade 2 and decreases for grade 3 onwards. Then similarly we have MAP, mean arterial pressure, is normal for this, but it starts to fall from second and third onwards. Is that clear? So systolic blood pressure, mean arterial pressure, heart rate. What else? What else? Respiratory rate. Respiratory rate per minute. When you talk about respiratory rate per minute, what are the important things? 12 to 20 grade 1, more than 20 up to 30 grade 2, more than 30 up to 40 grade 3. Persistently elevated respiratory rate beyond 35 can be anything, 3 or 4 depending upon the other parameters also. The next is urine output. So when you talk about urine output, let us see them in ml per hour. Average individual, let us take it to be 60 kg. So at a rate of 0.5 ml per kg per hour, more than 30 ml per hour is grade 1, 20 to 30 grade 2, 5 to 15 grade 3 and nil. The next is the mental status. The mental status. Now when we talk about the mental status, if you say hello to this patient, they are conscious oriented, so they will, with a very humble smile, they will say hello. They are anxious, they are restless, and these are, the last one is confused. Yeah. The next is, what is the treatment? When you talk about the treatment, one thing is very common. What is that, students? That is fluid. Yeah. So fluid. You have to give fluid. Yeah. So what is the fluid of choice? Fluid is equal to crystalloid. And crystalloid is equal to 0.9% NaCl. The next is we have blood and blood products. So blood transfusion is required for grade 3. Just a minute. So blood is required for grade 3 and grade 4. Yeah. Let us see one very important thing. But see, when we talk about crystalloid, what is the problem with ringer lactate? The problem with ringer lactate is that ringer lactate contains calcium, and if you have to go for a blood transfusion, the blood transfusion contains citrate to increase the shelf life, and they may show you a reaction. The second important point is the ringer lactate causes a faulty increase in lactate levels, and because there is faulty increase in lactate levels, you keep on resuscitating the patient with what, more and more soda bicarb, and ultimately there is a fault, you can say fault follow-up, and hence faulty resuscitation. So this is what is very, so therefore interferes with recovery. Are you getting this or no? So this is how we do. When you talk about monitoring of the recovery, of the patient, so we have certain parameters like urine output. Urine output is 1. MWAS is 1. So MWAS is overall the best parameters. This is most commonly used, most important clinical guide, and most accessible also. CVP, if you talk about, is the most unreliable. What are the other important parameters? Others are, you can use lactate. You can use NIRS, near infrared spectroscopy. You can use sublingual capnometry. They are important ones. Urine output, if you talk about, what is a normal urine output? More than 0.5 ml per kg per hour. This is for adults. More than 1 to 1.5 ml per kg per hour for kids. More than 2 ml per kg per hour. This is for infants. So students, this is all for today's class. We'll meet again tomorrow at the very same time. And I hope you enjoyed the lecture. If you enjoyed, do join plus using the code Surgery Live, or you can use the code Dr. Dixit also. Do give your feedbacks about the class. Do share the links. Yeah. Yeah, do share the do share the links of this class with your friends also. And in case of any doubt, feel free to ask me in the next class. Yeah. Okay. So till then, bye bye, bye bye, bye bye. I hope you enjoyed the class. Till